They said hair loss was permanent, but new science says otherwise. In this episode, Dr. Kyle Gillett reveals the secrets to reversing hair loss, what really works, what doesn't, and how your hormones might be the missing piece.
Good morning, I'm Dr. Kerry Gelb, and welcome to 1280 on Open Your Eyes Radio. Please listen as I discuss the newest information in the world of health, nutrition, and sports. Also, please share your thoughts by emailing me at drkerrygelb@gmail.com and visit my new website, wellness1280.com, where we have all guest links, Wellness 1280 info, and previous shows. According to published research, up to 38% of American men over 45 and as many as 80% of women experience hormonal imbalances. The reality is, most doctors receive little training in medical school on how to manage these complex hormone changes. Our guest today, Dr. Kyle Gillett, a Kansas physician who specializes in hormone pathology and is known for his expertise in helping patients with hard-to-treat and hard-to-diagnose medical conditions. Dr. Gillett's practice includes preventive and integrative medicine, aesthetics, sports medicine, hormone optimization, obstetrics, and infertility. Be sure to subscribe to his podcast, Gillett Health Podcast. Dr. Kyle Gillett, welcome to Wellness 1280 on Open Your Eyes Radio with Dr. Kerry Gelb.
Thank you. It's my pleasure.
So Kyle, or Dr. Gillett, up to 80% of males and up to a third of females suffer from hair loss. Can we really help baldness? And I got to ask you, is there any help for me?
Yeah, that's a good question. In general, it's kind of hard to tell how far gone you are in your case, if that makes sense. But usually once you're, there's a scale called Norwood scales. And the Norwood scale is more applicable in males than females, but a lot of females have hair loss as well, as noted. And in general, once you're past about a Norwood 3, then depending on how many transplant follicles, transplant plus other things is generally the main option. But there's a lot of ways that should be approached when someone starts to have hair loss. And this is what functional and integrative medicine is supposed to be, addressing the root cause, no pun intended. Before you hop on any sort of anti-androgen or PRP, you find if it's basic pathologies, like is your thyroid level too low or are you deficient in iron?
So, when I was young, I had wavy hair. It waved goodbye. So, a little joke, a bald joke. So anyway,
Nice.
Talk to me about finasteride, dutasteride. Do they really work and how do they work?
Yeah, finasteride and dutasteride, they're known to the layman as quote unquote DHT blockers, but this isn't technically what they do. They block the conversion of testosterone to DHT. And you could think of these two medications as somewhat opposite. Dutasteride blocks all three isoenzymes, but mostly 1 and 3. And finasteride blocks, again, all three types of those enzymes, but mostly 2. And basically what this means, to way oversimplify it, type 2 is concentrated in pubic skin, which is things like scrotal skin, labial skin, etc., and both males and females, of course. And then not as much in other skin. So if someone has excess sebum production, or even, it could be in the skin and the face causing acne, or it could be in the meibomian glands that's leading to more sebum buildup from styes. So one of the side effects of dutasteride is dry eyes, actually. And then one of the side effects of finasteride is dry, less sensitive pubic skin. And of course, it depends on what your baseline androgen levels are. And then also, to make it more complicated, it also blocks a hormone called progesterone that converts to these things that basically help relax. So after you give birth, after females give birth, their progesterone levels crash. And a lot of times that's one of the causes of postpartum mood symptoms. So some people who are on medications like finasteride can kind of have this finasteride syndrome, which can kind of have the mood symptoms or the OCD symptoms. And then it can also have like a little bit of almost psychosis symptoms. It is rare. It's probably only 5 to 10% of people, but you can also lose sensitization in the pubic skin. So all this sounds terrible, but they are very efficacious for preventing the progression of baldness in males and most females as well. Female pattern baldness is kind of just a different flavor of male pattern baldness. So in general, the level of efficacy goes from topical finasteride, which is applied locally to the scalp, to topical dutasteride, to oral finasteride, to oral dutasteride. There's a couple other unique benefits of finasteride over dutasteride. One is that it does not lower your sperm counts as much. And then one, if you're on a high dose, it can clear your system faster. So if you want to come off of it for theoretical epigenetic benefit, which is basically if you're trying to make sure that your sperm are not altered by these medications when you're trying to conceive, finasteride can be easier to get off. But other than that, dutasteride has better efficacy and less side effects.
And for topical, is it still have more side effects? Topical, or is equal topical is just oral where there's more side effects?
Topical works.
Dutasteride to finasteride.
Yeah, topical for both dutasteride and finasteride does not work as well. Topical finasteride is absorbed a lot because it has a smaller particle size. So probably about a third of topical finasteride is absorbed. It depends on the case. And somewhere between 1% and 5% of topical dutasteride is absorbed. There's actually not a study. There's only unpublished data for topical dutasteride. There's lots for injections, which are called mesotherapy. So if someone looks through Google Scholar and tries to find out what true topical dutasteride absorption is, they're not going to find it. So it's basically our best guess, but I do have a lot of patients on it. But the absorption of topical dutasteride at a very low dose is clinically insignificant. So for a lot of males that would potentially want fertility, like either banking sperm or conceiving a child soon, often topical dutasteride is the best option to go with. The problem is it's not FDA approved for androgenic alopecia. It's used off-label for many things, including PMS, premenstrual symptoms, or even PMDD, but only in areas like Korea is it approved by their FDA for androgenic alopecia.
And if somebody's using it for alopecia or baldness, are they using it every day, every other day? Topical, either one?
For dutasteride, generally once to maximum 3 times a week for most patients who may want to come off in the future.
And how about finasteride?
Finasteride is generally used daily. It doesn't have to be used daily. Sometimes every other day or 3 times a week.
And how about if it's oral? How many milligrams, how many times a week is it typically used? Each one?
For dutasteride, there's no set recommendation. What I do in practice is usually once a week or twice a week for most patients. For females, more often than that, especially if they're on an androgen, like testosterone. Again, there's no FDA-approved testosterone in females, which is a big issue, given that it's a hormone that is in female bodies and decreases as time passes. For finasteride, generally 1 milligram or 0.5 milligram every day or every other day. But as time passes, I have more and more patients on dutasteride and less patients on finasteride.
So you feel that dutasteride probably works a little bit better?
It has a much better benefit to side effect ratio.
And do you notice that men complain of impotence from using it?
Generally, no. The main complaint from dutasteride, without getting too graphic, is that things become a lot more watery. The other complaint that you hear from time to time is that their eyes are drier. However, their skin is better.
Interesting, since I'm an eye doctor. Now, how about saw palmetto? I mean, is it just a weaker cousin of these?
Yeah, there's several different molecules, naturally occurring molecules, that are 5-alpha reductase inhibitors of different types. There is some prostate benefit, but I don't think there's any significant hair benefit. So not worth taking for most people.
And people know about minoxidil. It's a stimulant for hair growth.
Mm-hmm.
Tell me about stimulants for hair growth. Let's start with minoxidil.
Minoxidil, PRP as well. I think you can think of them as fertilizers. So we actually don't know the specific mechanism of action. We've theorized about a lot of things.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
This is Dr. Kerry Gillett, and we're back with the Open Your Eyes podcast. And we're speaking with Dr. Kyle Gillett. His podcast is called Gillett Health Podcast. He has an Instagram, Kyle Gillett MD. Go visit him. So, Dr. Gillett, before the break, we were talking about fertilizer for the hair. Do these things really work? Does minoxidil really work? And how often should someone use it if it does work?
Minoxidil has excellent efficacy, and other growth agonists, even like latanoprost that I know is used in eye health quite a bit, also works, but generally not worth it for hair, by the way. And PRP also works. So minoxidil is actually a prodrug. When it's converted to minoxidil sulfate, which is according to your genetics, you might see a lot of these. There's dozens of companies that have very similar tests to basically see if you convert minoxidil into minoxidil sulfate. That's why sometimes it's combined with other things. And in the liver, minoxidil is converted to minoxidil sulfate readily. So basically what this means is, depending on your genetics, some people respond better or worse to minoxidil, but it always works to some degree. If you're a non-responder, then you can switch to oral minoxidil, although that has if you read the label, it has a warning for lactation. So if you're a male with gynecomastia or a female who has recently stopped lactating, then you might want to, well, actually, no matter what, chat with your doctor about it, but you probably wouldn't want to do it in that case. And then if you combine it with any sort of micro trauma, like scalp injections, microneedling, it works significantly better.
And can you stack it with finasteride, dutasteride?
Absolutely. I think that's what is known in the hair loss community as the big three, or really there's a big four because people don't really agree on what the big three is. It used to be ketoconazole and then either finasteride and dutasteride plus minoxidil. And now it is microneedling and or some sort of microtrauma. Dermaroling is a different, less good version of microneedling. I prefer microneedling plus dutasteride and or finasteride, plus or minus topical spironolactone, which blocks the androgen receptor, plus minoxidil.
Now, you mentioned latanoprost, something we use for glaucoma, a prostaglandin, and so do you take it and you do like take the latanoprost from the bottle and spread it out more? I mean, make it more liquid so you have more of it, because it's expensive, that stuff.
Yeah, it's extremely small concentrations. I don't remember the exact concentration, but I want to say 0.00 something.
Yeah,
And it's generally compounded with a whole bunch of other things in proprietary hair loss blends. But yeah, generally not worth it. Another interesting molecule for hair loss is PDE5 inhibitors, which are Cialis and Viagra, brand names or generic names of sildenafil and tadalafil. Sildenafil will grow eyebrow hair. There's no good studies on tadalafil, but it does theoretically improve oxygen delivery, which is another mechanism of hair loss.
And is that something that you'll stack together with the other ones, with minoxidil and dutasteride?
In some cases, yes.
And
yeah,
exercise also is good for blood flow, right? You recommend exercise too?
absolutely. Yeah, exercise and improving the balance of systemic and localized insulin resistance to insulin sensitivity is important. So there's some theories in any type of hair loss that blood flow is usually poor to follicles that die and that have their stem cell migrate away. And then there's also another theory that the localized insulin sensitivity in the hair is much better than the insulin sensitivity in other areas of the body. So there's a relative difference. And there's not a ton to take away clinically other than, like any other condition, good diet, exercise, and sleep is the most important.
It's interesting because we see when we treat our glaucoma patients with the prostaglandin agonists, how it grows the eyelashes. So we always joke that we should try putting it on our head and see if we could grow little hairs on the top of our head. But I guess you guys have tried it, and it does work to some extent. And
yeah, it does work to some extent. I just don't think it's as powerful as minoxidil.
And you mentioned ketoconazole, which is an antifungal, but it also prevents testosterone from going to DHT. That as a topical, how well does that work in shampoo when you put it in shampoo with, say, pumpkin seed oil or peppermint?
Yeah, highly variable. So as you mentioned, that is the combination that I like in shampoos. Over the counter in the United States can be up to 0.99% ketoconazole. And those are topical anti-androgens. They block the androgen receptor, more similar to spironolactone. In some patients, usually with mild alopecia tendency or progression, it can work. And anecdotally, it works best in those who wear a ton of hats and that have lots of really sweaty scalps, and they have subclinical bacterial and fungal infections, as ketoconazole can help with both of those things.
And how about caffeine? Is it topical caffeine that's used?
Yeah, topical caffeine does have some evidence. It is relatively weak, but there is relatively low side effects from using topical caffeine. So it can be reasonable. A lot of times if I prescribe a compounded blend, then I do include it.
And you mentioned microneedling. What is microneedling? How does that work?
Yeah, microneedling is tiny little holes, usually about 1 millimeter. You can adjust the length. Some people will go to med spas or clinics. We do scalp microneedling and even face microneedling. Some people may have heard of a vampire facial or microneedling for scar treatments, which also works quite well. And it can be done on the scalp. So there is a famous study of an older male that got a really bad burn on the scalp. And then years later, in an area where that he was quote unquote slick bald, he regrew a bunch of hair. So then we realized that little traumas like derma rolling or microneedling can help. Some people use a home microneedler, and I've tried it off and on for years, and it does work quite well, even if you do it once a month. Something like an intelligent microneedler is a good type. In our med spa, we use something called a skin pin, which most spas and clinics will have.
And does that hurt at all?
Sorry, is that
Is
what?
it painful? Is it painful at all?
In the temporalis area, which is kind of on the temples, it is extremely painful. And the other areas, not really. So I generally don't numb when I microneedle myself. If one of our nurses microneedles me or another patient, then we numb them with benzocaine, lidocaine, tetracaine. And then for patients that I teach to microneedle at home, we send them some similar numbing cream, even if it's just lidocaine, and have them leave it on for 30 to 60 minutes, wash it off well, and then they can microneedle it in with hyaluronic acid and or Botox-like peptides and or exosomes.
And how about PRP? You mentioned that before. If you could explain how that may work.
Yeah, so PRP is platelet-rich plasma, and you can do leukocyte poor and leukocyte rich. And the type doesn't really matter as much, but think of PRP as having a bunch of growth factors. If you injure something, your bloodstream will shunt more blood and growth factors there to help it heal. And this just helps it do that process faster. The more metabolically healthy you are and the younger you are, which might just be because you're more metabolically healthy in general if you're younger, the better PRP works. So you can inject it locally, almost like dermal injections when you get a TB skin test, just barely under the skin. And then you can also microneedle PRP in. That's what a vampire facial is, which you can also extend up into the scalp.
So they basically take your blood, they centrifuge it, and just use the platelets, and then you inject the platelets back in. And is that painful at all?
It's not as painful. It's not particularly painful. It feels cold, and it takes a couple days to have that heaviness feeling go away. But when I'm on a fertility protocol, then I certainly use PRP even for my own scalp. But it's also not an anti-androgen. So it certainly helps with the quality of the hair and it helps you maintain, but you wouldn't want to use just PRP in the long term.
And when you talk about fertility protocol, that means you're not using the dutasteride or finasteride because
Correct.
that affects fertility.
Yeah. For patients that are on normal doses, for patients that are on daily dutasteride, they need to come off for probably a year before they, just because of theoretical epigenetic risks. That being said, yes, lots of children are conceived where both males and females are taking finasteride and or dutasteride at the same time, and lots of case studies with normal children. But just out of abundance of caution, I have patients and myself, I stop 3 months before planning to attempt conception.
Have you seen any patients where it didn't go away, the ED from finasteride or dutasteride?
I've seen it for finasteride, I've seen it for saw palmetto, and I've seen it for prednisone, which is a type of steroid. And I've seen it from viral infections. I have not seen it from dutasteride yet. And some patients that have had this appear when taking finasteride. There's a lot of theories on why it happened, but each case is a little bit unique, similar to PCOS.
Wow. And going back to PRP for a minute, does that increase nitric oxide and VEGF?
Yes, PRP has VEGF in it. So VEGF is vascular endothelial growth factor. That's what BPC 157 upregulates, which basically helps new blood vessels form. And it's very high in younger individuals. Injecting it locally is pretty safe. You don't really want to do it IV in high amounts because it can also grow tumors. We block this for a lot of cancer medications.
Right. And Avastin in the eye, or someone has macular degeneration, will block it. But it could be a negative thing. Now, did you ever hear of EECP, external counterpulsation, enhanced external counterpulsation, to grow collaterals in the heart by basically using cuffs to cut off the blood supply? And you go back to the doctor every so often to try to grow collaterals. It's like doing a bypass without going through bypass surgery.
Interesting. I have not heard of that. I've heard of Russians injecting Botox in the heart for congestive heart failure that works well. And I've also heard of the Maasai tribe, who has huge amount of calcifications and plaque, but they grow collaterals just from running and frequent exercise.
Yeah, I mean, because, if we're gonna grow collaterals, especially with PRP, you're gonna bring more blood to the scalp, and the same way if you're using Cialis or one of those type of medications to increase blood supply. I'm speaking with Dr. Kyle Gillett. This is Dr. Kerry Gelb. His website, GilletteHealth.com. His office at GilletteHealth.com if you want to make an appointment. His Instagram, Kyle Gillett MD. We'll be right back after the break. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. So tell us, what percentage of men have ED about, and how common is it? And can we help these people?
Yeah, these numbers are changing very quickly. I saw one study claim that, and you don't put too much stock in any one study, but compared to 2014 and 2024, 40 times plus or minus as many males in their 20s have ED now compared to 10 years ago. And there can be a lot of reasons for that. Although testosterone levels are declining, it's probably not the main reason. And if you look at the percentage of males of any age where it's quote unquote psychogenic, or it's just in your head, it's actually about 40%. So more often than not, it's not just psychogenic. Yes, films and seeking out adult content on the internet does lead to an incongruence in what the normal arousal cycle is for males. So a easy first step is cutting that out. And that's actually the same for females as well. Lots of females have altered or compared to, depending on what their situation is, what their drive is, compared to what their partner desires, they also have altered arousal cycles. So there's a lot of tests that you can do for this, but often you can do therapies that are both diagnostic and therapeutic. For example, a lot of males and even females will go to the physician and hopefully they get good lab workup, look at their thyroid, look at their testosterone, and look at things like vitamin D even, and look to see if they're anemic, look at their sleep, see if they have sleep apnea. That's a common cause of both low testosterone and less morning erections, and then have the appropriate workup and then fix things. But more often than not, people will get a prescription of tadalafil or sildenafil. The dose matters, and how often they take it matters too. They inhibit an enzyme called PDE5, which inhibits phosphodiesterase E5, which basically causes nitric oxide to recirculate. So if you inhibit that enzyme really low, your body will actually produce more of it. So as it wears off, things could seem even worse.
And of all the medications that are used, which one seems to be the best?
Depends on the situation. What I like normally in males over about age 50, PDE5 levels increase more and more as time passes. So I think it's a relatively natural approach, actually, to bring those enzyme levels back down and inhibit them to a somewhat normal ratio. I like 2.5 milligrams of tadalafil as a daily dose if there's another benefit. For example, decreasing the amount of times that you urinate at night, or improving the health of the prostate, or even bringing down blood pressure a little bit, especially if someone doesn't want to take a bunch of supplements like L-citrulline or nitrosogene or beetroot. However, if someone wants to take one from time to time and they want it to wear off so that it is going to work best the next time, many people prefer sildenafil or even vardenafil for those reasons. And for optimization purposes, I want to optimize health, physical health, athletic performance, cognitive performance, and yes, sexual and mental and even spiritual health as well. So for sexual health optimization, I do like to use things that are synergistic. For example, if someone has higher prolactin, which kind of prolactin's what makes you feel blah. It makes what's called the refractory period very long. If it's difficult to have orgasms back-to-back or back-to-back days, then prolactin might be high. And of course, check this as well. Then APO works quite well to stack with it. And then for a lot of female patients, I like to use it with Vyleesi, which is bremelanotide, also known as PT141, which is similar to alpha melanocyte stimulating hormone, which it can increase libido in the same way that sunlight in the summer often increases libido. So for the right patient, there's a different ideal optimization strategy.
And for people that have ED, erectile dysfunction, is that a marker for heart disease or small vessel disease?
Certainly. It's what they teach you in medical school is the canary in the coal mine. So coal miners used to carry canary birds in there, and they would get sick, unfortunately, and stop chirping if there was carbon monoxide poisoning, and then they knew to go out. And it's the same thing, especially in a patient that has other risk factors for plaque in the heart or plaque in the carotids. Often it builds up in the arteries that lead to that area first, and that's a common cause of ED. In fact, high lipoprotein a, which is unrelated to LDL, is an independent risk factor for ED later in life.
It's funny about Lp(a). I've seen hemorrhages in the retina. And in the old days, I used to send them out to PCPs, and they used to come back, and it was always normal. They could never find it. They weren't doing the right markers. And I've seen a number of people in their 20s that had vein occlusions in their eye because of high Lp(a). So that's definitely a marker that should be checked, when people have a routine blood test. And I know it's not typically checked, but it should be. Same with homocysteine. I've seen hemorrhages in the eye from high homocysteine, something that's not typically checked, and something that probably should be a marker for inflammation. So about what percentage of people do these medications, these PD5 inhibitors, the Viagra, Cialises, that they don't work in? 40%, 30%? What percentage about of people does it not work?
Yeah, in most people, they partly work. In some people, if there's a patient that has developed it very slowly over time and has no other identifiable pathologies, sometimes it works quote unquote 100%, but most of the time, the effect wears off, or it works good the first couple times, then it doesn't work as well. So actually for most patients, it partly works. It's very rare that it does not improve things at all, because it is going to improve vasodilation of the corpus cavernosum and corpus spongiosum, which is just basically the vascular tissues that can expand. In both males and females, it works quite well, even in placebo-controlled trials. So for patients that it doesn't work as well enough, then you keep digging. I always tell people, if you dig deep enough, you will find things, but often, so you also do damage when you dig really deep. You can find things that cause mental stress or anguish, and you can also find false positive results.
You mentioned before 2.5 milligrams of Cialis. Is that something that has to be compounded, or you just break the 5 milligram tablet?
There's now a commercial product. I believe the FDA recently approved its indication for hypertension at the 2.5 milligram dose. So there's a commercial product. I prescribe a lot to pharmacies like Mark Cuban or GoodRx or Amazon home delivery pharmacy, and it's something like 5 cents per dose.
No, that's pretty cheap. And how does it help women other than increasing blood flow, decreasing Alzheimer's, blood pressure? How does it help? Does it help women as far as sexually goes?
Yeah, it does increase libido and drive. There's other things that can improve libido and drive significantly in females as well, especially in perimenopause and postmenopause. Depending on the female, there's a huge variation in androgen levels, up to 10 times. So, a normal male might be between 300 and 900, 3 times. But a normal female might be between 10 and 100 testosterone, a difference of 10 times. And then the free androgen index might vary even more. So we know that testosterone replacement or androgen replacement within reason also increases libido and drive and sexual satisfaction in many women. And then a neurotransmitter targeting does that as well. So there's a recently approved medication known as ADDYI, ADDYI. I have no compensation from the brand whatsoever. Haven't even gotten a free drug rep lunch from them. But basically it binds some random, what I would call them random dopamine and serotonin receptors, for example, D3 dopamine receptor, and then several of the serotonin receptors, which are known as 5-HT receptors. And they were actually studying it as a mood medication, and it increased libido as a, I guess, positive or potentially negative side effect in so many women that they completely repurposed it. And then earlier we mentioned Vyleesi, which is PT141 peptide, which is an analog of alpha melanocyte stimulating hormone, which is often released when you get sun exposure. And that one is also approved in women, but also works in males. So in women, often something more than just tadalafil or sildenafil is ideal, but I do like to utilize it.
And how about Gainswave? Do you have any experience with that? Do you know if it actually really works? And what is it, if you could explain it?
Yeah, is that the shockwave therapy?
Yeah, shockwave therapy.
Yeah. So theoretically, this will help both resensitize tissue and then also break up different scar tissues or plaques or things like that. And I've had a lot of patients get it. A lot of the patients that get it also have finasteride syndromes or post-finasteride syndromes. Not that that's super common, but they do seem to kind of seek me out for care. And for that indication, it has not seemed to help very much. Occasionally for a patient that is like, let's say they've had castration treatment for prostate cancer in the past, then it seems to be more helpful if combined with things like pumps or stretching devices, which there's many FDA approved ones, which are actually routinely used now if a patient has an aggressive prostate cancer.
And how about vacuum devices?
Yep, in the same category. So there's several options. There's a few that the Europeans tend to use and a few that the American urologists tend to use. But they all work to some degree, it seems. But for patients that have normal androgen levels and have not had to go through chemical castration therapy, there's generally not a reason to do it unless there's Peyronie's.
We were talking about using Cialis every day for general health. Is there any downside to that? And Dr. Gillett, what do you think?
Yeah, there's many dose-dependent side effects that can occur. It is a relatively safe medication, and some people even make the case that a dose like 1 milligram should be over-the-counter because it is safer than a lot of over-the-counter medications, including NSAIDs. However, headache is a very common side effect, which is dose-dependent. This can be post-orgasm headache, or it can be headache in general. It can also decrease your blood pressure slightly, but usually only a concern if you're on multiple other blood pressure medications. And then it can also increase intraocular pressure, which might be of particular interest to some of your podcast listeners. I've seen several studies, especially on higher doses of both sildenafil and tadalafil, that for those with a history of retinal detachment, then they have an increased risk of a subsequent or secondary detachment. We don't know if that has to do with the shape of the lens or the shape of the anatomy behind those areas, behind the retina, if you will. But it may lead to increased fluid in that spot. And I don't think it's well characterized, but there's a whole bunch of small case studies or case series on that phenomenon.
Well, thank you for that. I didn't even know that as an eye doctor. Well, thanks for that. How about tribulus? How's that? Is an over-the-counter supplement? Does that really work for ED?
Yeah. It may increase libido. It does not increase testosterone at all. Tribulus has been used for many years as an herbal supplement. So I do think that it is reasonable to try. Some people feel better, or they might feel like they have slightly higher testosterone on it. It usually does not work particularly well for ED. The reason why a lot of people think that it has worked in their case is they buy over-the-counter Tribulus. And I believe there's one study that looked at, let's just call them gas station pills, but easy to grab ED type supplements. And about half of them had Viagra or Cialis in them.
Oh, really? Not listed
So
on the label, huh?
the pill worked, but it's just
They
a
snuck it
question
in
of
there.
what it was in the pill. Yeah.
And the PD5 inhibitors, the Cialis, the Viagras, et cetera, do they increase testosterone?
Not that we know of. Occasionally, again, if someone is at more advanced age, I do include it in a natural testosterone optimization stack, but in and of themselves, not significantly. But they can help as part of a regimen.
Let me ask you about rapamycin. Is there something that you use that blocks mTOR? It supposedly increases lifespan, especially they've known in dogs that has increased it. Tell me about rapamycin. Do you have any experience with that?
Yeah, works fantastic in animals. I've had Irish wolfhounds, which is a type of large dog that gets a lot of osteosarcoma, a type of bone cancer. About a third of them do. And I did kind of dose one of mine that had a much longer than normal lifespan with rapamycin. I know that Matt Kaberlein is one of the founders or leaders of this dog aging project. So I think it's extremely promising for that. I believe they just lost their federal funding. I've been sending letters to people so that hopefully they get that back. Not to derail this podcast, I know it's not a veterinary podcast. And in humans, we don't know as much. There is interesting studies on egg quality during IVF harvesting and pretreatment. But there's also a case of someone that's with 5 milligrams once a week pulse rapamycin. I believe it was a study from China. But there's also a case report of someone who's in adolescence that was on rapamycin because of a kidney transplant, which is what it's most often used for. And she was not able to, she had a very poor quality when they did her stem protocol to harvest her eggs. So it's potentially beneficial and detrimental, probably given the dose and the protocol. And we just don't know exactly what that is at this point. It can be reasonable to use off-label in some patients who have cancers or precancers.
I know some, anti-aging guys are using it 5 milligrams once a week, blocking mTOR. Is there any, in your opinion, is there any benefit to blocking mTOR a little bit? And I'm not completely blocking it, but blocking it, maybe helping clean out the cells, autophagy.
Main downside is insulin resistance. So if you take enough of it, then your glucose will spike, and you can even develop prediabetes and diabetes while you're on it. That's why some people take it with medications like metformin or miglatol, or even very low doses of GLP-1s once a week. However, other common side effects is mucositis, like aphthous ulcers, which are known as canker sores. Then it can also worsen acne and even hair shedding. So depending on how you metabolize rapamycin, which changes as you age as well, it's metabolized through the liver, and you want to check a peak and a trough. So if let's say you check a peak about an hour after, which is when the peak level usually is, you want it to be between about 10 and 20. And you want your trough to be very low, probably 0.2 or lower when you're ready for your next dose. So if your level is still 1.5 a week later, then you might need to do it every 10 days or every 14 days. So if someone is on rapamycin, the generic for that is sirolimus, then they would definitely want to do peak and trough levels to know what their specific dose is. Some people need to take 6 milligrams to get to a high enough peak level for efficacy. Most of the people that are on non-commercial rapamycin, they get it from the compounding pharmacies. I don't think I've ever seen a level higher than 3 in them. So I switch all of them to the commercial product it must have different pharmacokinetics, that like it's not absorbed well enough or something like that. And then I see a lot of people that are on too high of a dose that have lots of side effects as well.
And, the people that you've seen on it that are doing it properly, do you think it's helping their health and helping their health span?
In some people, certainly so. A lot of times I'll do a test like an in vitae proactive panel or a hereditary cancer screen panel. This is for patients who perhaps they have a close family history that had ovarian cancer, breast cancer, colon cancer. They're screened for things like BRCA and Lynch syndrome, and they're negative, but they still want to dig deeper and know more. So you can test basically the 80 very clinically significant genes. And then if they're negative for all those, then perhaps that tilts you over the edge and you don't want to go down a protocol like a rapamycin protocol. But if they do have one of those, then perhaps you do, because if they have, let's say they have a gene that increases cell turnover, CHEK2 mutation is one of the random ones that I can think of. That is another risk for breast cancer that's not BRCA. And maybe they're not getting maybe they've had mastectomies, but they're at risk of other cancers. Then you can do shared decision making, because the benefit and the risk is going to be different for each patient.
And how about azithromycin, a Z-Pak, once or twice a year for autophagy to clean out dead cells in the body? What do you think about that as a repurposed drug?
Yeah, it's an interesting concept. I think there's likely better options, even herbal regimens. But the main downside of macrolides like azithromycin, if they're taken systemically, is they are relatively good at decreasing titers of Helicobacter pylori, which is a type of spiral-shaped bacteria that lives in the stomach. And in general, as long as your H. pylori is not too high, and as long as it's not the virulent strain, which causes infection and other negative sequela, then H. pylori is very protective against Crohn's disease and ulcerative colitis. So there's this second peak of Crohn's and UC, which are inflammatory bowel diseases, much later in age, even 60 plus. And the reason why this happens, and because previously it really just happened in people who are in their 20s and 30s, but a lot of people are getting it much later in life. And we think the reason behind that is fluoroquinolones like Cipro and macrolides like azithromycin to a slightly lesser degree. It's a dose-dependent effect, so one course is not unlikely to have a huge detriment. But because of that, I do think that it's better options for autophagy.
And what do you think are the good options for autophagy?
Caloric, for most people, caloric restriction to where they're in a maintenance, or to when they get to a healthy body fat percentage, which is about 22% for males on a DEXA and about 32% for females on a DEXA, is enough to get that autophagy benefit.
And any supplements? Are you a fan of spermidine or?
Yeah, often not spermidine. For 50 plus, I do like creatine monohydrate for cognitive benefit. I think that it's underrated. It's, if you look at the studies under the age of 50, it's probably not going to have a huge cognitive benefit. For patients that have family histories of neurodegenerative disease, I do think that Gillett makes a lot of sense as well, partly from a mitochondrial standpoint, and then partly just because it has fulvic acid. And we know that fulvic acid can help with tau tangle formation, which is one of the downsides to that. And then past that, I like psyllium husk, partly because it can help lower ApoB and partly for its gut microbiome benefit, healthy gut border, healthy blood-brain barrier.
As we finish up this podcast with Dr. Kyle Gillett, his website is gilletthealth.com, and Kyle has been kind enough to do another hour with us. So that look for next week where we continue this discussion. This is Dr. Kerry Gell for Open Your Eyes.
MacuHealth is a nutritional supplement leader. Our targeted formulas include MacuHealth for daily eye health, MacuHealth Plus for aging eye support, Vitreous Health for vitreous care, Vision Edge Pro for visual performance in athletes, TG Omega-3 for ocular and systemic wellness, and MacuHealth DM for eye and metabolic support. Call MacuHealth today and mention this podcast for special discounts. Experience the difference with MacuHealth. Nutrition you can see.